I just tend to think if somebody really wants recovery, like truly does, and just hasn't been able to get it, there's something we're missing.
I agree.
Because if you want, people can get sober in jail if they want to.
Absolutely.
People have gotten sober through AA.
100%.
The underlying most important thing is that they actually want it. And wanting it changes.
I think you're so right.
Yeah.
I've talked about that too with folks, is that we can have what we think is just a really incredible treatment program, but at the end of the day, the patient has to want to do this. With this podcast, what we're trying to do is have real, authentic discourse. Tammie, it's good to have you here today.
Great to be here.
Always good to have you. Love spending time with you. As you are probably aware, we are doing a podcast. This is our year of inauguration of it. It's called Treatment Redefined. And what we're trying to do is bring thought leaders in around the area of mental health, addiction, brain health, to really challenge the status quo on how people can get better throughout treatment. So, when I talk to families about this, and often I used to do a lot of the tours at the facility for families that were looking to bring their loved one in, and I work a lot with our admissions and intake staff on these types of things where you have people calling in, they have a need, and there's a lot of education that has to take place sometimes on the telephone because people don't really understand what treatment is and the role of therapy. And I was actually hoping, today's conversation would really shed some kind of inside light on that, because I would hear from families all the time that they'd had previous treatment experiences, and it was almost like they would send their loved one off and they go into the oven and they hope at the end of 30 days the bread is baked. Mm-hmm. And there's sort of always been this mystery, what's really going on around there? And I've wondered, well, maybe it's because people don't really want to show you what's going on around there. I think there's a lot, if you're doing it right, there's a lot of real quality work and a lot of moving pieces to this. Mm-hmm. And therapy, to me, takes time. And when you think about different settings that people can go, say you're suffering from substance abuse, really the status quo today is you go in and you probably get stabilized somewhere. And then you're going to move quickly. And a lot of it's driven, unfortunately, by the payer systems that we have. Yeah. There's these artificial constructs of outpatient, IOP, and PHP, and residential, and they're all insurance terms. But at the end of the day, what we're talking about is treatment. Mm-hmm. And what does it take to get somebody better so that they can have a fulfilling life free of those substances, that it doesn't interfere with them? And in those settings where you get stabilized and you're moved quickly to an outpatient level of care because that's what's been authorized, when you think about what people don't understand is there's not necessarily a lot of therapy going on in there. Mm-hmm. It's a lot of education. Mm-hmm. It's a lot of, quote, didactic, which is kind of educational groups. You're in big group settings. We're going to touch on some of that today, the role of group versus individual. But you're also moving quickly. You're not touching on things that are dealing with the family systems or the environment they came from. And I think my hot sports opinion of the day is that is one of the core reasons we have such high rates of recidivism.
Yes.
Because we have people placed at the wrong levels of care based on where the payer sources want to put them, when what they really need is some time. This is something that I don't feel like you can short circuit. Mm-mm. Like you said, you're going to spend the first several sessions just creating a bond, getting into my head, letting me develop trust with you. Then you're going to work a plan. You're going to truly develop a personal plan for me, something unique for me. I'd like to kind of hit on some of that and give people a feel for, if I was a patient that came in and I began working with you, how are you crafting that plan? Like, what is it? People use this term, I think, so loosely. It's, we do a personalized treatment plan. What does it really mean?
Yeah.
How do you really create a custom plan for me?
Yeah, the treatment plan is much bigger than just the document that's in your chart.
That's right.
And you're right, because there are so many people who are trying the least intensive interventions for the most difficult chronic illnesses to treat, right? When, we have a lot of people who come to us and they've maybe been to a lot of facilities, but maybe the thing they've been doing most recently is just seeing an individual therapist in the community. And I'm sure their therapist is great, but if you're still drinking or if you're supposed to be on a mood stabilizer and you're not, you are not getting what you need to get out of those therapy sessions. And that therapist is probably a little confused about some of your behavior and why it is that you haven't been able to do any of the interventions they're recommending, right? And so we do get a lot of recommendations from those therapists who are ethically saying like, oh, well, now that I know this is going on, you need to go get help and then come back, right? But it does take figuring out. We have a great team that helps to get these people into our facility, talks the families through the thing, gets a chance to interview the patient, and assesses whether we are a good fit for them. We have a lot of information just up front.
That's right.
And that's so helpful for us. It helps me kind of know, well, what therapist do I think this person should be assigned to? So that's first, like based on these things that we know, the limited information that we know, what is the best person to kind of,
work with them.
Work with that person. And then we have, usually a period of stabilization and them sort of normalizing to the community. If it's detox, then, they might be a little crusty at us popping in and saying, hey, I'm your therapist. Do you want to talk? Like, do you feel good enough to talk? But we're going to try. Yep. And we don't push. If you're not feeling up to it, just get better. Just incubate, But once people start getting around, we're going to start kind of prodding and wanting to get you into some groups and wanting to see you how you naturally operate.
Yep.
And that's not really going to be your baseline either, because you're probably still not feeling very good. Post-acute withdrawals can last a very long time.
That's right.
And a lot of the times if it's mental health, their medications are probably not working like they're supposed to. We're not seeing this person in their ideal state. But we use the information that's given to us, plus collateral information from family members. That's super, super important to be able to talk to the family, because some patients may lack insight and some patients may not be at the right level of readiness for change that we really want them to be.
Yep.
And that's something no one can change. Nobody can make somebody be ready for this. And it's hard.
See, I think you're hitting on something kind of interesting that I think is unique in the way that we do treatment, and we talk about it. And one of our other clinical directors that had moved down to outpatient now, Lenny, has talked about this, is being active directive.
Yes.
And maybe just touch a little bit on that, because I think this is kind of a unique, I've learned to appreciate this, is that the role of a therapist working with substance abuse patients in a residential setting, for lack of a better way to say it, you really just can't sit back and let them move through the treatment program, saying, I've always heard I won't work harder than the patient wants to work, kind of these lines you hear over the years from people. And I think, but they need it.
Yes.
Because they're not thinking right.
That's right.
So you have to take a much more fall forward approach, don't you know, with patients.
Yeah. And we see that, we recognize addiction as a chronic brain injury, brain disease, something that this person will likely struggle with for a lifetime. Harder at first and not as much if they have some success down the line, right? You make new lifestyle changes. But when we're getting somebody fresh off their active addiction, what we know is that drugs and alcohol affect the prefrontal cortex the most, right? And that's the part of our brain that is required for making good decisions and for understanding consequences and managing impulses. And so it's not all the time that we have people who are demonstrating a real deficit in that area, but we do have quite a few. So we love it when we have somebody who's in the right area of motivation. There's less sort of directing that we have to do.
That's right.
But if we were to do the traditional therapy thing of helping guide this person to their own conclusions, oftentimes their conclusion would be, I'm just going to go back to using.
Exactly.
It wasn't that crisis. It wasn't as bad as everyone thinks it was. I can go back and manage it and moderate. And that would be a very bad decision, because we know that the trajectory of those decisions is back to Enterhealth or a place like it.
That's right.
And so, it's kind of it's a cultural thing at Enterhealth. I don't know if it's like that at other places, but at Enterhealth, we will tell you if this is a bad decision.
Yes.
Right? We will tell you if the way you're thinking about this is what is causing your problems. And it is not a traditional way of doing therapy, but it is necessary for this population, because if we let them to their own devices, oftentimes they'll lead themselves right back into the same cycle that they've been in.
I completely agree. I mean, unfortunately they're with us for a reason. We're having to help them make better decisions.
Yeah.
You know, and often what leads people to come get treatment with us is their family members are the ones that lead them there, because they're not able to really think through this and realize how severe this problem has become in their life. You know, their relationships are getting destroyed, their marriages, you know, lack of relationships with kids and family members. They sometimes need somebody else that's in a different state of mind to say, it's time to grab you and we got to get you some help.
Yes.
And so it takes time, again, going back to the time aspect, time and treatment to break through and help them realize, you know, they don't know that they necessarily have to hit that proverbial like rock bottom. Mm-hmm. Because sometimes they come in and they're not quite sure if they need to be in treatment. Maybe there's an outside motivation for them, you know, to be in treatment. It could be legal issues or divorce or risk of divorce, things of that nature. But I've always felt like you don't have to hit rock bottom. No. You just need to be there. And then we go to work. Mm-hmm. And you may have somebody that's very willing, very motivated. You may have somebody that isn't motivated at all and doesn't understand why they're there and has full plans to use as soon as they get out. But I'm a big believer that at the core of every patient that we've seen over the last 18 years, that they don't want to be living the life the way they're living it.
No.
So you have an opportunity, right?
You do. Sometimes people, I call it like negotiating with terrorists, right?
Yeah.
Like they think that they can have their cake and eat it too with some things. And they start questioning how big of a crisis really was this. And oftentimes, depending on the amount of substances in their system when they came in, may not really have been in the same situation as their families were with them, right?
That's right.
We all have a different perception, and the perception is our reality. And so that's why bringing family in is invaluable. I mean, we really couldn't be successful if we weren't doing this.
So let's hit on that just briefly. We've talked a little bit about treatment, what goes into it, a lot of different aspects of it. Mm-hmm. Today we're talking about the main thing is therapy, but there is medical and neuropsychological and environmental and spiritual. Within the therapy world, family. And right or wrong, we've decided since the very beginning that we would take the families on from the beginning. Mm-hmm. You know, it was suggested to us, well, you should do a family weekend. Mm-hmm. Come out and let them spend some time with their loved one, give them some education. Right. Family week, possibly, mainly doing kind of their own therapy with other families, getting a chance to interact with their loved one. We tend to take it on all at the beginning. And I think that's one of the reasons why we've always tried to keep our caseloads as low as possible, because even though you might have a therapist working with 5 patients, they're really working with more than that when you think about taking the family on. Mm-hmm. But it's important, right? Mm-hmm. I mean, being able to address the family systems issues, would you agree, is vital to their recovery ongoing?
Yeah. And depending on how long we have someone, you know, we can accomplish more or less of the most important goals. I'd say conceptualizing what family problems are my problem and what family problems are the next therapist's problem is definitely important, because I have to remember this patient is my patient. Mm-hmm. And so when we have family therapy, my goal is for this patient to be successful. And so almost all of the sessions in a family setting at Enterhealth are going to focus on how do we educate the family about this problem, right? It's not the person, it's this. This is the problem, right? Mm-hmm. And how do we talk about that?
Right.
And how do we make sure that that stays where it is, right?
Yep.
And so the family therapy is going to be about, sometimes we're going to delve into, hey, this is a codependent system. Do you guys know what that means? And how do we break out of that? How do we set boundaries to where if you're angry, I'm not angry just because you're angry, right?
That's right.
How do we create new structures in the family system to support this person's new goals? How are we creating accountability for this person and who's responsible for what?
That's right.
And I think the biggest thing for me is relapse planning or lapse planning, right? And everyone hates this. Yeah. But we have to talk about it.
Have to.
And this is a huge differentiator between Enterhealth and other places. We're going to talk about the elephant in the room.
That's right.
That this is a chronic lapsing disease. We think, and in some ways know, because we are looking at our outcomes, right? We're going to be more successful.
That's right.
But we also can't cure this. We can't cure it. I wish we could.
Mm-hmm.
And people have been trying for ages. And there's people trying right now with all sorts of snake oil. I won't say snake oil. I'm sure some people get some benefit out of it. But with all sorts of claims that this is curable if you just do this thing, right? Mm-hmm. And it's not true. We know because our patients have had these cures.
100%.
And so we really have to get real here. Mm-hmm. What are we working with? And how do we prepare the family to manage this and have the best functioning possible?
That's right. And I don't think it's, you're right. People don't like to talk about it. Mm-hmm. Families on the front end don't really want to talk about it that way either because they want to send their loved one off and have them fixed. Yep. But the fact of the matter is it's not going to be like that. But there is a positive outcome that can be had. Mm-hmm. And I'm kind of a believer that your life can actually be richer than maybe it was before you got into a lot of this trouble, because just because you've had some trials and tribulations doesn't mean you can't have a successful life. Mm-hmm. I've met a lot of people and they just have a different perspective because they've been tested in different ways. And I think going through periods of time where you've had substance abuse problems and life challenges, if you can course correct and understand how to help yourself be free of those substances, you might still have the cravings or the desires. You might even have the lapse in your course of trying to get better. Mm-hmm. That doesn't mean you have failed.
That's right.
It's progress still, and you're still pursuing a successful life. And I think you can have a very enriching life with having had those experiences. Mm-hmm. Then, pass it on down to your children, your experiences that'll keep them from maybe engaging in some of those same behaviors. Yeah. But, going through treatment, I was talking about this with Dr. Latif the other day, is that it's not always about getting somebody back to the point where they felt like they had a problem and had to go into treatment. Mm-hmm. I don't think that's what treatment's about. It's actually helping them I want to hear your opinion on this, but helping them understand what got them off track, but let them have a new path to kind of go down in life and have more fulfilling, enriching relationships and success. Because you only have one life. As far as I know, I don't think we're being reincarnated. So we help people get their life back and have a positive rest of their life free of substances.
Yeah. And as long as that person sort of has the right education that this is a brain disease, as long as that person continues to maintain, we call it even being in the maintenance level, stage of change, as long as they still want this, it's theirs. Like if somebody wants it and they have the right tools and they know enough about themselves, they can have it, right? Yep. That's the biggest thing. Do they want it? And I would say, one of the things that we do super, super well at Enterhealth that I'm really proud of and I get very excited about is giving people those answers they've been looking for. Mm-hmm. I just tend to think if somebody really wants recovery, like truly does, and just hasn't been able to get it, there's something we're missing.
I agree.
Because if you want, people can get sober in jail if they want to.
Absolutely.
People have gotten sober through AA.
100%.
The underlying most important thing is that they actually want it. And wanting it changes.
I think you're so right.
Yeah.
I've talked about that too with folks, is that we can have what we think is just a really incredible treatment program, but at the end of the day, the patient has to want to do this. Yeah.
But there's underlying things, right? There's things that people come to us with that they don't have a name for yet, but they know, their family members know. Mm-hmm. And one of the interventions that we often are doing, besides sort of doing the talk therapy, doing our psych eval, working with them in treatment team, sharing our observations about these people, is getting a very fabulously credentialed neuropsychologist in to do a big old long test on them, right?
Yep.
Man, I cannot tell you the number of individuals that have come in and we've started coming up with a hypothesis, right? There's something off here.
That's right.
And we get that test done to sort of rule that out or confirm it. And these people have gotten some big breaking news answers.
No doubt.
And to the point where, like, if we had known this was what was going on, we would have definitely saved years of suffering. And it takes a huge weight off of people when they put a name to it. And, we practice functional psychiatry. We've practiced holistic treatment. Yep. We are not the kind of facility that just wants to label you, stick a sticker on you, and send you off. But sometimes getting a diagnosis is life-changing.
I couldn't agree more. That's why I find our field so exciting, because it's actually very, very complex.
Yes.
But there's some simple truths in there too. And I think being able to bring in, like you were talking about, the neuropsychological testing, the QEEGs that we do on patients that would come in on the front, that's objective criteria. It's one thing to get a diagnosis from a therapist or a doctor who is telling you what they think. I mean, it's based on experience and their training, but it's also to have something objective that can kind of corroborate that. It's extremely powerful. And like you said, it can be like groundbreaking news. Like, maybe this explains some of the way my thinking is or the difficulties I've been having.
Yeah. It definitely helps us as therapists too, because, oftentimes we already have kind of an inkling of what's happening. But it is, again, it's one thing to say, I think this is what's going on. Let's go over the diagnostic criteria. And that's helpful in and of itself. And that's how traditional diagnosing happens, is you meet criteria. But that's also complicated, because diagnoses or conditions can look like each other. Misdiagnoses happen all the time. If I go to see you, my psychiatrist, and today my symptoms are feeling hopeless, feeling like I can't make decisions, having a hard time concentrating, maybe a little bit down and depressed, then that is what the snapshot is of me for the day.
Yep.
But the next week could look very different. And depending on what symptoms I'm experiencing when I see you, that's the impression that you have.
That's right.
And that also informs what medications I'm taking and what interventions I'm doing and what kind of therapies I'm doing.
That's right.
So having somebody for this period of time, getting a lot of eyeballs on them from a lot of different people with a lot of different experience, we start to put this piece of the puzzle together that really, really, really helps.
Exactly.
And I just can't tell you how excited I get when I know somebody is going to get that intervention and do the testing, because it's a big piece of the puzzle.
It's often revealing some things they probably need to hear, right?
Yeah.
Okay, let's just segue just a touch into an area that I think is a big part of treatment, which is trauma, dealing with trauma.
Oh, yes.
There's maybe it's in other areas, other types of specializations in treatment, but like when we're in substance abuse, trauma is a big issue we have to contend with.
Yes.
How do we treat it? What is the right way to treat it?
Yeah.
How's it integrated into treatment, like at our facility or in your eyes? What do you think is like the best way to approach this?
Yeah, it really just depends on the person. So it's, again, one of those things where you can't say, we can sit down and say, what's Enterhealth's program?
Right.
But there's hundreds of them, right? So somebody who comes in and they have childhood trauma that they're resistant to talking about and working on, or even disclosing fully, but it's old trauma, we could probably do something with that, right? One thing in talk therapy that we know is that those early experiences are informing the way that you move throughout the world, right?
Yep.
So in a talk therapy setting, even if we're not talking about this specific event, we are talking about how the trauma lives in you, right? So we say, we don't want to live in the past, but hey, the past lives in you, right? You cannot shake some of it. So some of the ways that we relate to other people, our ability to stick through conflict, how we feel during conflict, or whether or not we can be consistent in relationships or in work. And all those things are created, right? You're molded through a lifespan. And so you may not want to talk about it, but I can see it, right? It's hanging out.
Yep.
And so I'm going to talk about it. And my goal would be to sort of say, hey, I know you don't want to live in the past, but here are these things, and here's how I think there's a golden thread from here to then. And I think it'd be really beneficial for you to look at this, actually.
Yeah.
And so for some patients, we're going to recommend them into trauma therapy. And trauma therapy is a lot of different things.
That's right.
We have a very, very skilled clinician who's one of my favorite people in the entire world who headways our trauma program, and she's amazing. And she's just got this knack for helping people get there. And there are going to be some people who, just based off of the amount of resources they have in them, have a really hard time getting there. So we don't jump right in with EMDR, eye movement desensitization, and reprocessing, right? This is a very popular intervention for people with trauma that helps you sort of reprocess traumatic memories into ones that aren't disturbing in the here and now. We will do something different with you. She will do something different with you. She will meet you where you are and help you get there, right? So your trauma journey may start at Enterhealth and probably won't end at Enterhealth because trauma is different.
Yeah, I would think it would take some time to tease some of that out. You know, I'm listening to you, and I'm also thinking about, you know, how people look at trauma is, I think it could be looked at differently depending on the generation you come from too.
Goodness.
You know, I think about, like, I'm a Gen Xer, raised by baby boomers. I always like to tell people I'm an only child raised by a Marine from Abilene. And so I was, you know, not necessarily probably raised with the idea that, you know, things that might be tough are going to create traumatic situations for you. So I think, okay, if there's other people that are, you know, raised in a similar type of fashion kind of growing up, how do you really, because you're kind of putting a label on it as trauma. Someone, you know, might say, well, that wasn't trauma. That was just the way I was raised. And then you got to kind of start teasing some of that out, don't you? To say, well, let's not put maybe a label on it, but let's look at how those situations are, you know, dictating how you're functioning.
Informing your here and now.
Exactly. So that's a process, right? Because I would think you've got to get people to be able to see it first.
Yeah, and if you're me, I'm extremely directive, so I'm just going to say it, right? I'm just going to say what I think is happening. And some people who, you know, may or may not be from your generation, or, you know, your dad's generation, respond in different ways to that. Some people intuitively know there was some stuff that happened, and like the way that I was treated, or the way that, you know, these different things went down. And, you know, as a segue, hopefully I get back here because I have a problem with squirreling off. But as a segue, like, you do have to remember, like, even parenting, like, styles and parenting, like, things that were in vogue informed this. There was a certain period of time, like in the 1950s, coincidentally, when, you know, things like powdered formula came onto the market and things like that, where it became very unstylish to breastfeed, right? Or to pick up your child when they're crying. And what we know now is that early contact is super important for attachment. We didn't know that back then. We thought we were spoiling children by taking care of their needs. And so there's a whole generation out there
you're right.
that was raised basically basically trained as an infant to put away their own needs and to give up when asking for help, which don't make me cry, Dave.
That is super interesting, actually.
But where was I at?
No, I loved it, actually, where you were kind of going with that. Just looking at the generational things of, like, the 50s when, you know, you had these children that were at such a formative age, not realizing, because you're learning and processing and laying these, like, mental tracks down at such a rapid rate. It's like, you know, there has to be a God, because it's just amazing how the brain is growing at such a fast rate. But that attachment, like, animals know this, though. I mean, I just got 2 little puppies, and I'm watching them with our daughter's other dog, and just it's an instinct. You know, they know you're young. They know you need to be taken care of. They feed you. They love you. We've had different generations go through phases where I think it was a different type of, no, you don't need to do that. You can put them down.
Absolutely.
Don't get too close. They need to be kind of independent.
That's right.
Otherwise, they're going to become spoiled and attached to you. And I don't know. I don't know where we are today. You know, I'm a parent. I've got 3 children. And I think each generation is like this, by the way. I think they try to take, and I even say this to my daughter, who's just got a most wonderful boyfriend. I hope they get married someday, honestly. But I say this to her. I was like, take the best of what you learn from, you know, your mom and I, and take the things that you would like to improve upon, and toss it away and build your own family. And so I think these generations, they try to, that's probably called improvement. You know? Progress. But I do think, just going back to, like, the healing trauma, I think everybody's got elements of it.
They do.
That's the thing.
What I was thinking.
Okay, it's not like hey, I was sexually assaulted or I was taken hostage or something. Like, I'm not trying to put labels on those things, but there's a lot of different things that happen in life that probably fall into kind of traumatic instances for people.
Yes. All a defense mechanism is a rule you created for yourself. So if you have a defense mechanism of as soon as conflict hits, you leave, you learned it somewhere, right? You didn't just do that because at some point in your development, you learned when things get really scary, when somebody is angry, it's safest for me to leave.
Yep.
Right? And so what we have to do when we start kind of identifying these things, and the plan is, okay, how's it working for you now? What is the consequence of you continuing to do this thing that you learned as a 6-year-old or as an 8-year-old?
Yep.
And what's the thing we want to do? What's the most helpful for you in your here and now in your real reality, not your little kid reality?
That's right.
And start trying to expose people to a new way of doing things.
Yep.
And so that is a lot of what therapy is.
It is, isn't it? Mm-hmm. It's really a beautiful thing when you think about it. It's Everybody nice. Could benefit from it.
They all need to go.
Everybody.
Yeah.
Oh, all right. Well, let's kind of conclude all of this with just talking about. I want to link some of what you had mentioned earlier about. Look, this is an issue that we're going to learn to manage.
Yeah.
I've been talking about it. Continue to talk about it. Time is important. It doesn't always have to be. You don't have to come live in a residential center for 5 years, but you need the requisite amount of time to build, I call it the base foundation, to build your house of recovery on. Mm-hmm. So let's get those foundational elements in place. Let's work on them. We're going to put the structure together, build the foundation. Now we're ready to go to work. That happens in outpatient. Mm-hmm. But it can also be an entry point for people as well. But for the sake of this conversation, the word continuum of care, continuing, how important is it in your mind that proverbial passing of the baton from a residential level of care to outpatient?
I mean, it's more beneficial. Let's just say we have an example of somebody who says I can either do another week of residential or 2 weeks of residential, or I can do the IOP. Mm-hmm. Do the IOP, right? Do it, because you don't want to go. It would be like going and getting surgery on your knee, and then just walking right out of the hospital on it, right? Like,
it's a great analogy.
You're good, but like you're gonna ruin it.
That's right.
Yeah.
That's exactly right. I feel like that's like we're in the acute care setting with residential, but in outpatient, we're doing a lot of the rehab, aren't we?
I always tell people you cannot purchase your recovery.
Yep.
So what you've done here by going to treatment, that's a really good thing and a really good first start, but this is a lifelong illness that you have to take seriously. We do not want to drop you from at Enterhealth. It is so lovely. Yeah. Okay. You got your meals. The meals are delicious. You didn't have to cook it. You didn't have to do the dishes, right?
That's right.
You got people checking on you, saying hi every day. Your cabin is comfortable. No one's messing with you. Right. Your kids aren't getting up every 30 minutes, not personal.
No.
And saying they need something from you, right? You are there to focus just on you.
That's right.
And that's not how life is. So we do call it the pink bubble a little bit. We want to have fun. We want to take it light because we're doing heavy stuff. But it's an enjoyable experience for people to be at Enterhealth.
Yep.
Nobody denies that.
That's right.
Your real life is different.
That's
and
correct.
your work is different, and your stressors are different. And if you try to go back into that environment thinking, I'm done, I did my time, you are very, very likely to run into a situation where you haven't thought about this yet, and you go back into the old pattern.
That's right. That's right. So just generalizing, and I know it's hard to do that sometimes, but if you have a patient that goes through a course of residential treatment and then they engage in an outpatient level of care, just in your mind, are there like certain like benchmarks or thresholds of like, say, look, if I can get my patient through really the first, say, 60, 90 days in an outpatient level of care where you've got wrapped programming, could be group programming, continuing with med management, individual therapy, family work, as they go further and further staying engaged in outpatient treatment, their success continues to rise and
Yes.
rise, does it not?
It absolutely does.
And in your mind, what's that critical period of time? If you, like listeners were saying, okay, my loved one's about to get out of treatment, you'd say, look, we need to make sure they are immediately engaged in that outpatient programming and continuing for what type of time period in your mind?
A year. Right. So, and that year can include, when you started at residential.
That's right.
What we are looking for is 12 to 18 months of brain healing, right?
Yep.
That essentially just means time where you have taken your meds, taken your vitamins, gone to the doctor, not used any substances, gotten good sleep, the basic life stuff.
That's right.
That we have done 12 to 18 months of good, solid work. And that point, you can reduce the interventions. Now, there are some people who need to be in therapy still after 12 months, not 12 years. But I would say that really what our goal is from residential is let's move you into an intensive outpatient.
Yep.
And then reduce that a little bit to a supportive outpatient, reduce that into a maintenance.
That's right.
And then keep doing therapy. You want to have a combination of natural and formal supports.
Yep.
So you want to have people in your camp, your friends and loved ones, and you want to have people in your camp who are professionals, who are there to kind of see you and see if you're doing well.
Right.
And those, if one doesn't catch something, the other one will.
Yep.
And if we're talking to each other, we can prevent the crisis, right? So that's the big goal. Let's get to 12 months. And a lot of people feel very overwhelmed by that, but we have to remind you, brother, we've been doing this for 35 years.
That's right.
We've been drinking, we've been using, we've been whatever is going on, being dysfunctional in some way. I know it feels like a big deal, but 12 months is really nothing.
It's a drop in the bucket when you think about it.
Yes,
it
it's
really
an investment
is.
in yourself.
It is. And, I always like to kind of, as we talk about these complexities, is that give people the fact there is hope for this.
Yes.
If I had a loved one, my wife needed to go through treatment, for instance, I would be confident in saying, listen, just submit and be willing to learn. Go through, follow the recommendations, medically, therapeutically, submit to it. If you will do it, you will get better.
That's right.
You will get better.
You will improve. You will not get worse.
Correct.
Absolutely.
Yeah. Well, I have to tell you, today has been an absolute ball talking to you. I always enjoy spending time with you, Tammie, and I'm so fortunate to get a chance to work with you and you be on this journey with us. So thank you for being with me today.
Thank you. Thank you for everything, the opportunities. I love it here. I'm so happy to be here to talk about Enterhealth, and yeah, it was fun.